Okay, so today we are going to talk about RBC. 1 minute. Today we are going to talk about RBC. Okay, everyone can see. Okay, everyone can see my slide. Okay. So today we are going to talk about the RBC, that is a red blood cell, or also called as a erythrocytes. What does mean by erythrocytes? Erythro stands for red color, and cytes are the cells. These cells are called red blood cell because of its color, and that color they get it from the colored pigment, that is heme. Heme is a part of hemoglobin. Heme is a part of hemoglobin. That heme gives a red color to the RBC, and because of that red color RBC, blood is also look red. So first we see just little bit of structure of the RBC or morphological features of the RBC. It has one unique shape. RBC has that unique shape. It like a biconcave disc, which is a biconcave disc, which has a very thin in the center and thick at the periphery. So it is like a disc shape और फ्रैम्बी डिस्क खेलते हैं जो पेरिफेरी में सॉलिड होती है बीच में बड़ी थीन होती है सर्कुलर दैट्स व्हाई दिस because of the biconchave disc shape it increases the surface area of the RBC so that there is a more cell membrane of the RBC is present as compared to its volume. Now if we see the actual shape of the size of the RBC, so it ranges from some 7 to 8 micron. On an average, 7 micron is its total diameter. And if you see the thickness, the thickest at the periphery, which is somewhere around 2 micron, and the thinnest at the center, which is somewhere around 1 micron. And this unique shape of the RBC will increase its surface area, and that is somewhere around 120 to 140 micrometer squares. What is the advantage of this surface area? Why RBC का surface area में क्यों बढ़ाना है? So many times we think that it's because of availability of more surface area, we'll have made better gaseous diffusion, and that's true for gaseous diffusion or any diffusion. Surface area is one of the positive factors. So more is the surface area, better with the diffusion. But in RBC, apart from that, more important function of this high surface area is that because RBC has to move through the capillaries, which has a smaller diameter than the RBC size. Size of the capillaries also is there. But when they are moving through that smaller capillaries, these RBCs squeeze and they change their shape. And because of the squeezing, they move out. And because of that high surface area, it reduces the stretch on the cell membrane because they have a high cell membrane for a given volume. So whatever shape will change, there's no more requirement of the surface volume. Suppose the RBC has a oval shape or a circular shape, then the circular shape has a maximum volume for the given surface area, or they had a lower surface area for the given volume. So if you change any shape of that cell, then it will increase the surface area. Stretch on the cell membrane, that will increase wear and tear of the cell membrane, and that leads to more damage of the RBC. And that is what advantage of RBC. So it makes RBC very flexible. Apart from the providing diffusion. Yes, Dinesh. Yes, Dinesh.
Sorry, sir. Unfortunately, I think it's
Now come to the count. RBC is somewhere around, it's present in the blood somewhere around 4 to 6 millions per cubic ml of the blood. So when it is increase in count, we call it a polycythemia. When it is decrease in count, we call it as a anemia. Okay. So first we'll see the variation in the size shape of the RBC. So first we'll talk about size. So whenever there is any change in the size or whenever there is a variation in the size, that condition we call it as a anisocytosis. Aniso means unequal. So unequal size of the RBC. So when there is a decrease in the size of the RBC, then we call it as a microcytosis. So when our volume of the RBC is decreased, then we call it as a microcytosis. And in microcytosis, you can see in various conditions like thalassemia, iron deficiency anemia, then this is osmotic pressure and all those things is not a clinical, But in anemia, iron deficiency anemia, and thalassemia, you will get a micro size of the RBC. In macrocytosis, when the size increase, RBC size increase in the size, we call it as a macrocytosis. That you typically will see when there is a megaloblastic anemia, or when there is increased production of the RBC. Then there is no more time is available for maturation of the RBC. That time it become little bit larger size. And the megaloblastic anemia you will see in a deficiency of vitamin B12 and folic acid deficiency. Then come to the variation in the shape. Normally, it is a biconcave disc shape of the RBC, but variation it can be different shape of the RBC. So that condition is called poikilocytosis. And that poikilocytosis, it can be like a spherical shape when there is a damage to the membrane protein, that is pectin. Then this RBC acquired spare shapes. And because of the spherical shapes, RBC has a very less surface area and it causes more wear and tear of the RBC, and that can cause more destruction. Hemolytic anemia, spherocytosis. Then elliptic psychosis, where kallikrein is a protein which is affected, and because of that, RBC acquired the elliptical shape than biconcave disc shape, and that also leads to similar condition like that of the spherocytosis, and it also leads to hemolytic anemia. The another condition is sickle cell shape, and the sickle cell shape, there is no problem with the membrane, but it is a problem with the hemoglobin. There is a defective hemoglobin synthesized, and that hemoglobin in that beta chain is affected, where valine is replaced by the glutamate, and that hemoglobin which form is called HbS, sickle cell hemoglobin, HbS, and it has a high tendency to precipitate when they are exposed to the low oxygen level. Yes, Amisha. Yes, Amisha.
Nothing, sir. So by mistake. Sir, the thing is that I'm traveling, so I have some network issue. Hello?
Okay, now I stopped that feature also to allow raise hand. Okay. Uh, then in that, because of that has a tendency to precipitate the hemoglobin. Now that hemoglobin get precipitated, and it make the RBC very much rigid, and they acquired a crescentic shape of the RBC. It like something like this. And this is called sickle cell anemia. It's okay, beta. And this crescentic shape, this as this become rigid, they trapped into the small capillaries, and it start destruction of the RBC. Not only that, but it also sometimes causes infarction of that organ. This is called sickle cell crisis. And poikilocytosis is a different shape of the RBC that you can see in sickle cell also, where wear and tear occur. All these three conditions also, apart from the spherical shape, you will see a teardrop type of the RBCs or fragmented RBCs. All those things you can see, and that condition is called poikilocytosis. Any other hemolytic anemia also, there also you will see poikilocytosis. Sometimes you get a okay, better. चैप्टर सीक्वेंस वाइज तो मुश्किल आपको बताना। आप मुझे व्हाट्सअप करो, मैं व्हाट्सएप पे आपको लिस्ट लिख के भेज दूंगा कौन से सीक्वेंस में पढ़ा है और कौन से सीक्वेंस में पढ़ना चाहिए। This condition is called picocytic, where different shape, like the 2-3 conditions can also come together, and that leads to different type of the different shapes of the RBC, and then we call it the poikilocytes. Then come to the variation in the counts. So when there is increase in count, we call it as a polycythemia, but if physiological increase को हम polycythemia नहीं बोलते. Physiological means when there is a no disease, and normally it increase. So if you see at the birth, infant is already in a hypoxic state in intrauterine life, and because of that they already had a higher RBC count. So immediately after birth, the RBC count is much higher. Then after birth, up to the 10 day, it decreases because of rapid destruction, because these RBCs doesn't contain adult hemoglobin, but these RBCs usually contain fetal hemoglobin, that is called HbF hemoglobin. And because of this, they rapidly decrease in the first 10 days of the life, and that will lead to lower RBC count. And as the age progresses, they will attain the adult RBC count. But always in an early age group, the RBC count is always slightly little bit more than the adult. Second thing, RBC count is much higher in the female as compared to, RBC count is much higher in the male as compared to female. And it is firstly because we usually consider it is menstruation, but it is not a menstrual cycle which is responsible for this, but it is a presence of testosterone in the male. So testosterone has a high stimulating effect on the erythropoiesis directly also, and it also increases the effect of erythropoietin on erythropoiesis, and that's why there is a higher RBC count. Erythropoiesis is the process of formation of new RBCs. That condition is called erythropoiesis. Formation of new erythrocytes is called erythropoiesis. Okay. This next condition is altitude. When you will go at the higher altitude, as you move higher, and if it is usually above the some 10,000 feet height, oxygen concentration goes lower, and that will lead to stimulate the erythropoiesis by releasing the erythropoietin by the kidney, and more RBC will form, and that leads to increased RBC count. Then severe exercise. Whenever you do severe exercise, there is sudden rise in the RBC count in your blood. It is because of increased sympathetic activity that will cause severe vasoconstriction, and the RBC is present in the peripheral pool, like they're present in the spleen, present in the GI tract, present in the skins. That all RBCs will push into the central pool, and that will increase RBC count. Okay, it is not like that the hypoxia होता है exercise के बाद and then erythropoiesis होता है. So hypoxia is not a condition, though it is written, but hypoxia is not. It is usually splenic contraction which increases the RBC count. Then there is a emotional conditions. Whenever you had extreme emotions like extreme joy, happiness, sorrow, rage, fear, in this condition it increases the sympathetic activity, and that will cause vasoconstriction. And because of vasoconstriction, there is a release of the RBC from the peripheral pool into the central pool. Similarly, after meal, immediately after meal, there is increase in RBC count. It is because of whenever you had a food, the need of the blood to the GI tract will be increased, and so to meet the supply of the blood to the GI tract, it will cause vasoconstriction of the skin and vasoconstriction of the muscles, and blood from the muscles and skin will divert it to the GI tract, and that will lead to increase RBC count. Then come to the pathological cause. So when there is increased RBC count pathologically, that is, it is if more than 14 millions count, then we call it as a polycythemia. And if that polycythemia doesn't have any cause, then we call it either polycythemia vera, or we call it as a primary polycythemia. This is usually cancerous condition where uncontrolled proliferation of the bone marrow will occur, and that will lead to increased RBC production. Apart from the RBC, it also leads to increase of platelet and WBC also, and that's why name is given polycythemia. The secondary polycythemia, here when the person is exposed to the chronic hypoxic conditions, Like when there is a chronic lung diseases, then also there is increased RBC count, like a chronic obstructive pulmonary disorder, COPD, or in that condition, there is a difficulty in the respiration that leads to person for a chronic hypoxic condition that will lead to increased RBC count. Apart from that, congenital heart diseases, where normally what happens in congenital heart disease, this is right side of the heart, this is left side of the heart. Right side, it goes to the lungs. Okay, it take from the body, blood comes, then from here it goes to the lungs, and from lungs the blood get oxygenated, come to the left side of the heart, and from left side it goes to the rest of the body, oxygenated blood. So this portion contain deoxygenated blood, and this portion contain oxygenated blood. Okay, so again I will draw again it. So this is right side of the heart, and this is left side. So right side contain deoxygenated blood. My voice is too low. Now is it okay? Okay, right side of the heart is a contain deoxygenated blood, so O2 नहीं होता यहाँ पे, and left side of the heart contain oxygenated blood, so O2 is present. Now in congenital heart disease, what happens? There is a defect, septal defect, either ventricular septal defect or atrial septal defect. So there is a bridge between these. And if you know, left side has a high pressure circulation and right side has a low pressure. So normally what happens, this oxygenated blood will mix to the deoxygenated blood, and it is always hyperoxygenated. So the oxygen level is always high. Okay. So this is how the congenital diseases work. But there are some conditions happens where the blood is not moving from left side to the right side whenever the defect is occur, but it is in opposite from right side to left side. So deoxygenated blood is already mixing to the oxygenated blood, और यही blood body में share हो रहा था. The body में जो blood जा रहा, it is a mixture of both oxygenated and deoxygenated. So actually blood which is supplying to the body will not have a 98 saturation or 100% saturation, but it will somewhere 50-60% saturation, and that's why it creates chronic hypoxic condition, and that leads to secondary type of the polycythemia. अब ये conditions कैसे होती है? Suppose it is more detailed, like in tetralogy of Fallot, there is obstruction to the pulmonary artery, and because of that obstruction, heart has to apply more pressure to push the blood into pulmonary artery, and the pressure which generated will be much higher, and now blood will moving from right side of the heart to the left side of the heart, because of it has to generate high pressure, and pressure will be higher than the right side has higher pressure as compared to left side. So this is one condition where this happens. Second condition, as the normal septal defect है और left side से right side में जा रहा है, and the more and more blood is going to the lungs, and as the lung is receiving more and more blood, lungs start developing resistance to the extra blood, so that it will not damage the lungs, and that resistance, the veins provide more and more resistance to the blood flow, and that will keep on increasing the pressure within the lung, and that condition is called pulmonary hypertension. And sometimes the pulmonary hypertension keep on increasing, it can goes up to the systemic blood pressure, and now pressure generated by the right side of the heart will be almost equal or more than the left side of the heart. Now blood will move in opposite direction. पहले इस direction में जा रहा था, but after few years it will goes into the opposite side of the heart, and this again will lead to oxygenated blood, deoxygenated blood mixed with the oxygenated blood, and body will supply with the low oxygen. That again leads to polycythemia. So then come to the another condition where a decrease in RBC count. When RBC count decrease, it's called anemia, but it is always pathological. Physiologically, we don't call it as a anemia, and it can be seen in pregnancy is one of the commonest condition where you will see decrease RBC count, and it is not because of actual decrease in RBC production, but it is because of RBC production is increased, but at the same time plasma protein production is also increased much higher, and that will lead to actual hemodilution. So if you take a total body's RBC content, it is higher, but if you take the RBC content of blood per cubic mm, it is little bit lower, and that's why it is a physiological anemia. Then with the sleep and other conditions also, there is a decreased RBC count. Pathological condition, we'll have separate topic. So by end of this class, we'll discuss about the anemia in detail. Then come to the, okay, these are red cell indices. These are not much important. I'll share this slide. You can go and read it. Then ESR also, you can go and read. Then come to the structure of red cell membrane. Okay. Red cell membrane, it is a bilayer structure, which is made of both lipid and protein. And it also contains lipids like glycolipids, phospholipids, and cholesterol. And protein also contain the integral proteins, peripheral protein, and structural proteins. And these also contain like a protein like a lecithin or sphingomyelin. And then, there is a polysaccharide bond that's responsible for the blood group antigens. Then inner surface also contain a phosphatidylserine and phosphatidylethylamine. And there is a peripheral protein like spectrin and anikyrin, which is responsible for the spherocytosis and erythrocytosis. And also actin protein is also present on their surface, which is responsible for the maintenance of size and shape. Uh, okay, first thing, reason behind the decreased RBC count in the sleep. Like during exercise, there is increased activity that will increase the sympathetic blood flow that squeezes the RBC into the blood. Similarly, during night time, the sympathetic condition is very low, and blood circulation will be a little bit slower, and that makes the sequestration of the blood into peripheral tissue. So the more blood will be in the legs or skin, and so that it will cause little bit decrease in RBC count. It is not a remarkable, but little bit decrease in the RBC count. That's why I didn't discuss also in detail. Trilaminar structure is another name of the lipid bilayer. So it is like there is lipid, protein, and lipid. So it is similar like the cell membrane, but here they have mentioned it as like a trilaminar structure. Then see the permeability of the cells. It is allowed to permeable to the oxygen and carbon dioxide, and also like chloride or phosphate or bicarbonate ion. Along with that, urea, ammonia, aldehyde, and alcohol. While it is impermeable to the amino acids, proteins, sodium, glucose, barium, fat, and sugar. Then composition of the RBC. RBC is almost it's 60% of the weight of the RBC is made up of the water, while the remaining 40% is made up of the solid. Out of that, 35% weight is of the hemoglobin. If you take only dry weight of the RBC, means if we remove the water and we'll take dry water, 90% of the weight of the RBC will be contributed by the hemoglobin. Then other components, which is 5%, are nothing but the enzymes which required for the survival of the RBC and other structural proteins. These proteins include like glutathione, albumin, like insoluble proteins, and also these are prevent RBC from the reducing agent. And then there are various enzyme systems are present in the RBCs like glycolytic enzymes, catalase enzyme, carbonic anhydrase enzymes, and these are important for the survival of the RBC. So in this glycolytic system, here the RBC is one of the cell which utilize glucose only as the source of energy. Another cell is the neurons, and it doesn't require insulin for the entry of the glucose, while all other cells, neurons and RBC, doesn't require insulin as a gateway for the entry of the glucose inside the cell. They can take glucose even in the absence of the insulin. Another, remember this carbonic anhydrase, it is very important for transfer of the carbon dioxide from tissue to the lung. Then glucose and also some small amount of the amino acid also present. Then ions, all these are present. Okay, we will not go in detail about this. Then metabolism, glucose is the only fuel which utilized by the RBC, and this usually goes by the facilitated diffusion always from the blood to the RBC. They doesn't require any other mechanism. And 90% of the glucose is metabolized by the EMP pathway, which is the commonest type of the mechanism. EMP pathway, or is also called as a glycolytic pathway, and it is a oxygen dependent pathway. Remaining 10% will be shortcut taken by the glucose, and that is called HMP shunt, which produce less energy from the glucose as compared to EMP pathway. And by synthesizing this EMP pathway, this whenever the more and more glycolysis will occur, it starts synthesizing more substance, that is 2,3-diphosphoglycerate, and that concentration of 2,3-diphosphoglycerate will keep on increasing the RBC as the age of the RBC increases. And this is also responsible for the low affinity of the hemoglobin for the oxygen. Then come to the formation of the RBC, which is also called as the erythropoiesis. And all cells are formed, blood cells are formed in the same place. So we total together formation of the RBC, WBC, and platelet will together will consider as a hemopoiesis. So first we'll see the site of the hemopoiesis. So immediately after fertilization, and that is in the first 2 months of the gestation, the blood cells are formed in the yolk sac. By the end of the 3rd month, organs will start developing, and then liver and spleen will start developing. And now liver and spleen will take over the charge of the development of the blood cells. So after 3rd month, the liver and spleen will become the site where the blood cells will be formed, and it will continue form till the birth of the individual. But from the 20th week of the gestation, bones are also start developing. And now bones, along with the bones, bone marrow will also develop inside the bone. And now RBC will start developing into the bone marrow also. So by the month of the 4th or 5th month of the gestation, now RBC will develop from the both liver and spleen, and also from the bone marrow. And this is called a myeloid stage of the hemopoiesis. Okay, and it will continue to increase the production of the RBC in the bone marrow as compared to liver. So production of the RBC, WBC in the liver will start decreasing, while it will keep on increasing. And by the 8th or 9th month of the gestation, now bone marrow is the main site for the formation of the RBC, and spleen and liver will become very small site for the production of the RBC. And then just after the delivery, within a few weeks, it will formation of the RBC in the liver and spleen will completely stop, and now it will exclusively taken by the bone marrow. Now after the birth, bone marrow is the only site where the RBC can be formed. So in the adult, it is a bone marrow where the RBC can be formed. But as the age increases, at the time of the birth, almost all bone contains bone marrow, which can form the blood cells. But as increases, this bone marrow which forms the blood cells are called red bone marrow, and this red bone marrow will start replacing by the fatty tissues, and they becoming non-proliferative, and those bone marrows are called yellow bone marrows. So slowly as the age increases at the adult, only few flat bone like a skull, sternum, ribs, pelvic girdle. Here, where the red bone marrow will be present, while long bones doesn't contain any bone marrow except the end of the tibia and end of the femur, where small portion of the red bone marrow will be present. Otherwise, it is present only on the flat bone in adult. Then erythropoiesis. All cells are formed from the common origin, that is called hemocytoblast or pluripotent progenitor cells. And from there, the different cell will form, like a erythroblast cell called erythrocyte cell will form, we call erythroblast series, where the granulocytes will form called myeloblast series, where the lymphocyte will form lymphoblast, monocyte form monoblast, and the thrombocyte form the megakaryoblast series. And those series will produce individual different type of the cell. Now, once the progenitor or stem cell will be there, it will get stimulated by the various factors. The most important factor is erythropoietin, and that erythropoietin will convert it into erythrocyte progenitor cells. And that is called megakaryocyte erythrocyte progenitor cells under the influence of the erythropoietin. And same erythropoietin will act on these cells and start making it more mature RBC. So while coming from the megakaryocytes, erythrocyte progenitor cell to the RBC, it goes into different stages. And first stage form is called pro-erythroblast. Blast cell is called a precursor of the cell. Cell means site means cell. So site का precursor is blast. और ये blast का precursor है pro-erythroblast. Okay. So from progenitor cell, it will become first a precursor of the erythroblast, that is pro-erythroblast, which very large cell, and it contains more of the basophilic cytoplasm, that's a bluish in color, and very large nucleus. As it start progressing from the pro-erythroblast to the erythroblast, the size will start shrinking, and cytoplasm will become more and more acidophilic. The chromatin will become more and more clumping and more strong, and it will become smaller and smaller till it comes to the erythroblast. Now, it from the basophilic, it start becoming acidophilic because of from the intermediate erythroblast, it started synthesizing the hemoglobin. So hemoglobin synthesis will start increasing and increasing, and its hemoglobin content will start increasing till the late erythroblast. The nucleus will be removed, excreted out of the erythroblast, and now reticulocyte will form. That is just precursor of the mature RBC, and these RBCs will release into the blood either as from the RBC or as the form of the reticulocytes. Now these reticulocytes are called reticulocyte because of its typical nature. When we stain this reticulocyte with a supravital stain. What is my supravital stain? Normally, when you stain any cell, we usually first kill that cell. That is called fixation. We'll kill that cell, and then it will take up the stain. But in a supravital stain, we'll stain the live cells. So we incubate it, and we'll incubate them into the stain. And now stain will be actually taken up by the RBC, and that will stain the material which present inside the reticulocyte. That material is nothing but the remnant of the various endoplasmic reticulum, and that will stain a little bluish color, like a network-like structure will form at the center of the RBC, and that is called, because of the network-like structure, it is called reticulocyte. Reticulo means network. Okay, and as it get mature, that network is also removed from the RBC, and the mature RBC will be formed into the bone marrow. And throughout this stage, erythropoietin catalyze or increases the progress of the development. So what will happen? Size of the RBC will start decreasing, size of the nucleus will start decreasing, and amount of the hemoglobin content will start increasing into the RBC. Then come to factors which regulate the erythropoiesis. There is only one factor which regulates the erythropoiesis, erythropoiesis, that is erythropoietin. It is a hormone which is released by the kidney, that is a juxtaglomerular apparatus of the kidney, and it is a glycoprotein which has a molecular weight somewhere 34,000. And the major stimulus for this erythropoietin is hypoxia. Now the new factor is come. It is not like erythropoietin is directly released by the kidney, but kidney release the renal erythropoietic factor, and which act on a globin that is called as a erythropoietinogen and convert that erythropoietinogen into erythropoietin. Okay, even if you say erythropoietin is released from the kidney, then also it will not wrong. Or if you say this also, then also it is not wrong, because this is a newer fact which came, and that's why I added this fact in this slide. Poietin is given name. इरेथ्रोपोइसिस को जो प्रमोट करता है, दैट प्रोटीन, इरेथ्रोपोइसिस को प्रमोट करने वाला प्रोटीन, इरेथ्रोपोइटिन. ओके, then how erythropoietin help in the erythropoiesis? Erythropoietin act on each and every site of the erythropoiesis. So throughout the site, it exert effects on a stem cell and differentiate it into erythropoietin megakaryocyte progenitor cells. Then once the megakaryocyte progenitor cell will be differentiated, then it increases the synthesis of the RBC and also increases the synthesis of the gamma aminobutyric acid effect, and that causes more and more synthesis of the globin inside the RBC. It also formation of the maturation of the erythrocytes into mature red cells. Yeah, normoblast and erythroblast are same. And it not only that, it also promotes the release of the RBC from bone marrow into the blood. That normoblast name is given because there another erythropoietic mechanism we'll discuss. When there is a deficiency of the vitamin B12 and folic acid, that time the size of the RBC will be little bit larger than a normal RBC size throughout the stage. Even pro-erythroblast, late early pro-erythroblast, late pro-erythroblast, all those things will have larger size. And that time we don't use word erythroblast, but we use word megaloblast. So with reference to that megaloblast, this erythroblast, we call it as a normoblast. Okay. Then factors which increase the erythropoietin secretion. So remember this slide very at a concentration से इसको ध्यान में रखो, because many times you get MCQs on this. So what are the hormones which can increase the secretion of the erythropoietin? Hypoxia, hypo means low, oxia means oxygen. So whenever there is a low oxygen concentration in the body, we call it as a hypoxia. Or whenever the oxygen cannot be utilized by the cells in the body, or we can call it low oxygen in the cell of the body, then we call it as a hypoxia. Okay. Then come to the factors which increases the secretion of the erythropoietin. So there are many hormones which directly or indirectly act on the erythropoietin and increase secretion of the erythropoietin. Now, first and most common is androgen or testosterone or male sex hormone, which directly increase the secretion of the erythropoietin. Another is thyroxine. It not only increases the erythropoietin secretion but also promote its effect on erythropoiesis. Apart from these other hormones like growth hormones, prolactin, ACTH, and steroids, they also has effect on erythropoietin and increase their secretion, and also some hormone has effect on increased erythropoiesis. This point, Raise your hand. Erythropoietin act and increase the hemoglobin. It increases the hemoglobin synthesis by increasing the globin synthesis. So globin formation, globin की synthesis by the erythroblast वो promote करता है. और वो कैसे promote करता है? By increasing the activity of gamma aminolevelic acid synthetase, which is important for the synthesis of the globin. This is a mechanism of protein synthesis, and by doing this, it also helps in the conjugation of the globin and heme part, and promote the formation of more and more hemoglobin. Then another important factor is a hemolyzate. Hemolyzate are the product of the RBC destruction. जब भी RBC destroy होगा, so there are fragments of the RBC will release into the blood, and that products are called hemolyzate. And this hemolyzate will directly act on a juxtaglomerular apparatus and increase formation of the more erythropoietin, and also it directly act on the bone marrow and increase formation of more and more RBC. The nucleotides like cyclic AMP, NAD, and NADP, these nucleotides also directly act on erythropoietin and increase formation of more erythropoietin. Then vasoconstrictor drugs, any vasoconstrictor drug which generalizedly act will also cause the vasoconstriction of the kidney renal arteries. And that will lead to apparently decreased blood supply to the renal artery, and there will be low oxygen concentration in the renal blood, and that leads to artificial hypoxia, and that can increase the erythropoietin secretion. So it doesn't mean that if you have anemia, then you give vasoconstrictor so that it will increase, because it will cause vasoconstrictor other part of the body, and it will also increase the blood pressure also. That will be more harmful to the body. We had a better way to treat the anemia, so we will not use this type of the drug. Then there are various factors which decrease the erythropoietin secretion. One is adenosine antagonist, like a theophylline, which oppose the effect of adenosine. Low oxygen concentration in the body is called hypoxia. Hypo means low, oxia means oxygen. Another condition is called hyperoxia, where high concentration of the oxygen in the body. Hyper means high, oxygen means oxygen. Okay? Then estrogen hormone, which has the opposite effect like that of the testosterone, and it will decrease the formation of globin chain in the liver, and it also decreases the effect of erythropoietin on the erythropoiesis, and also decreases the response of the erythropoietin to the hypoxia. And that's why female has a low RBC count as compared to male. Then factor which is required for the erythropoiesis. All these factors which promote or inhibit the erythropoiesis, but there are some factors which required, and these are the जब भी कोई चीज प्रोड्यूस करते हैं तो उसके लिए हमें रॉ मटेरियल लगता है. So we need a raw material. What are the raw material? One is a protein and another is iron. So whenever there is globin is a protein. बेटा पहला क्लास नहीं अटेंड किया है क्या तुम लोगों ने? प्लाज्मा प्रोटीन वाला क्लास नहीं अटेंड किया है ना? वो भी नहीं पढ़ा है आप लोगों को. Okay, next class I will take about on plasma protein. Protein are three types in our body: albumin, globulin, fibrinogen. So उसका जो globin part है वो protein. Okay, next class we'll talk detail about all these proteins. Okay, then there has to be raw material, iron has to be there, and protein also there. So proper nutrition should be there to increase the erythropoiesis. So erythropoietin होके कोई फायदा नहीं if there is no iron or if there is no protein. Second thing, for erythropoietin synthesis also we need a protein. So that also has to be there. Then there are some other factors which is important for the maturation of the cells. And this is a factor of vitamin B12 and folic acid. Vitamin B12 and folic acid are must for the formation of DNA and RNA. And they are important for the maturation of the cell. And when these factors are deficient, as RBC production is continuously going on, so here what will happen? Cell get matured, but nucleus will not get matured faster. So nucleus is lacking the maturation as compared to cell, and that will lead to decreased formation of the hemoglobin or decrease more maturation that will keep the cell in larger size. And that's why it is called megaloblast. And this megaloblast will release into the cell, and that condition is called megaloblastic anemia. This can be seen in both vitamin B12 and folic acid. So there I told about requirement. 1 to 2 microgram per day is required, and we can store the vitamin B12. Body can store it for the requirement for whole 1 year. So अगर आज आपके body में पूरा vitamin B12 है, and from this year if you don't take for another 1 year, you will not show any sign of the vitamin B12 deficiency. By the end of the 1 year, if you continue not taking vitamin B12, then you will see the sign of deficiency. And folic acid requirement is 10 microgram, 100 micrograms, and hair storage is not much higher, so we need to supply it daily. And this both will lead to decrease in both leads to formation of megaloblastic anemia. Now come to the hemoglobin. This both helps in DNA synthesis. Both vitamin B12, yeah, vitamin B12 is water soluble. So erythrocytes contain almost total 34 to 38% of total volume content consumed by the hemoglobin. And hemoglobin is synthesized into the RBC from the heme and globin part. Heme is called conjugate part. This is an example of conjugate protein, and it contains conjugate part, and globin is a protein part. So they combine together and will form hemoglobin. The most important, why we need hemoglobin into the RBC, because if you see the functions of the RBC are nothing but the function of the hemoglobin. So RBC is just like keeping the hemoglobin in the one purse. एक purse में रखा हुआ है, and with that purse it is moving into the blood. So what will happen if hemoglobin is not present into the RBC and it can directly present into the blood? Oxygen वो भी carry कर लेगा, but it will create more problem. The amount of hemoglobin we required, if it available free form in the blood, it will increase the viscosity of the blood. So in blood की viscosity increase होगी, and that increased viscosity will causes increase in blood pressure because it creates the resistance to the blood flow. There will stagnant blood flow. Apart from that, it will also increase the osmotic pressure, and that osmotic pressure will drag the fluid into the intravascular space, and that can increase the blood volume. Next thing, this hemoglobin will directly release into the from capillary into the tissue, and they will keep on depositing into the tissue, and there will more and more damage of the hemoglobin or destruction of the hemoglobin by the tissue. Now we need to synthesize more hemoglobin than right now our body is doing. Apart from this, the hemoglobin has a very low molecular weight, and it can easily pass through the Bowman's capsule and goes into the urine, and it can excreted into the urine, and that is called hemoglobinuria. And our body will lose hemoglobin, a lot of hemoglobin in the urine, and we need to produce more and more hemoglobin. To avoid all these problems, the hemoglobin put together into the RBC so that all this problem will not be there. And that's why RBC is very important to maintain the hemoglobin. What is normal hemoglobin count? It is somewhere around 40 to 80 in the male and 12 to 15 in female. If you see in the fetus, it is a little bit higher concentration, that is somewhere around 16 to 19 gram percent. A gram per DL means 18 gram in 100 ml of the blood. DL stand for deciliter. That is also called as a gram percent. Okay. Then immediately after birth, if you see, it goes up as high as 23, because while delivering, the baby has exposed to a lot of hypoxia, and that stimulate more and more RBC synthesis. But immediately after birth, the hemoglobin start falling because of rapid destruction of the RBC, and it will become lower immediately after 10 to 12 days, and then it will slowly stabilize and come to somewhere around 10 to 11 gram percent by the end of third month, and it will slowly increase and come to the adult level by the end of the year. Then come to the structure of the hemoglobin. It has a molecular weight somewhere around 68,000. If you know, okay, I didn't taught you. If you know the lowest protein is present in the plasma, which has a 69,000. So it is lower than the albumin molecular weight, so smaller than the albumin. That's why it can easily pass through the Bowman's capsule. And it contains the pigment conjugate part, that is a heme, which contain iron. So first we see the structure of the globin. Globin is a polypeptide chain. It is made up of the 4 chains. And there are 3 types of the hemoglobin. Hemoglobin A, hemoglobin F, hemoglobin A2. Normal hemoglobin I'm talking. And adult में जो होता है hemoglobin, उसको बोलते हैं hemoglobin A. A stand for adult. And it contains 2 alpha chain and 2 beta chain. Out of this, alpha chain is smaller, that is contain 141 amino acids, while beta chain which contain 146 amino acids. They combine together and forms hemoglobin A. Then come to the structure of the heme. Heme is made up of the iron porphyrin complex. So this is a structure of porphyrin ring. These 4 porphyrin rings will combine together with the iron and form ferric iron heme structure, and this all heme will combine with the all alpha and globin chain. Okay, this is how the hemoglobin will form. स्ट्रक्चर ध्यान में रखो. Porphyrin ring होती है, the 4 porphyrin ring will combine together, and in the center there will be the iron. This together will form iron porphyrin complex. And this iron porphyrin complex, 4 iron porphyrin complex will attach to the different end of the globin. That is usually CH negative part of the globin, and they will attach there. Okay, so this is how this globin chain will be there, and this ferrous ion which present here. This ferrous ion has affinity for the oxygen, and here the oxygen attached to the globin chain. If you see normally loose iron is available in ferric form, then it converted into ferrous, and then it put into the porphyrin ring, and this ferrous ion has a very high affinity for the oxygen, and combine with the oxygen to form the and this doesn't react chemically, it just attach to each other, and they will remain higher affinity for the ferrous ion as compared to oxygen, and it can easily replace oxygen from the site, and that's why carbon monoxide poisoning is very dangerous. Okay, now how the hemoglobin behaves with the oxygen. So these 4 chains are like sisters or friend, you can call like that, and they're staying together. So if one sister attracted towards the oxygen, suppose one chain is attracted to oxygen and oxygen attached to this side, and O2 will add to this side, then this make the all other 3 sisters jealous of this one chain, and now they also increases the affinity for the oxygen. Now suppose second chain, here is oxygen attached, Now once the both sisters is getting, now other two sisters become more jealous. Unko kyun mila, hame bhi chahiye. And now the other two chains has a much higher affinity than these two for the oxygen. Suppose third chain also attached to the oxygen. Then तीनों को मिला और मुझे क्यों नहीं? Fourth chain has a more higher affinity, and they strongly attract the oxygen, and oxygen attached to them. So this is all how they carry the molecules. So there are 4 molecules of the oxygen will attach, or 8 atoms of the oxygen will attach to the one heme molecule. And because of this nature of the hemoglobin will carry more oxygen when there is more oxygen available, like in the lungs where more oxygen is available. And this mechanism is called loading of the oxygen. Okay, so it causes loading of the oxygen on the hemoglobin. Now suppose once it's completely saturated, now they go to the area where the oxygen saturation is low, and that can remove the oxygen from the one chain. And once the one chain removes the oxygen, similarly like other sisters, अरे उसको पसंद नहीं है, ये चीज अच्छी नहीं होगी. Now if one oxygen is removed, suppose this oxygen is removed, now other three will loses the affinity for the oxygen. Now they don't have much attraction for the oxygen. And then another oxygen will also remove. And as the two will remove, these other two will also loses the affinity. Then third will also remove. And if 3 chains are removed, then fourth will also loses, have very low affinity for the oxygen and lose. And this mechanism is called unloading of the oxygen. And because of this typical nature of the hemoglobin forms a very good carrier of the oxygen. So जहाँ पे oxygen ज़्यादा है, वहाँ से ज़्यादा oxygen ले लेता है, और जहाँ पे oxygen कम है, वहाँ पे ज़्यादा oxygen deliver कर देता है. Then come to the function of the hemoglobin, जो अभी मैंने बताया, transport of the oxygen. So it carries the oxygen from the lungs and attach itself. It doesn't react chemically. Remember, they just attach. Chemical reactions नहीं होता. It is not oxidation of the hemoglobin. And hemoglobin which attached with the oxygen is called as a oxyhemoglobin. And this oxyhemoglobin is a bright red in the color. Okay, and then it goes to the lungs, and where they release the oxygen at the tissue level. Sorry, tissue level, and the more it will release at the tissue level. Now, when they're attracting toward the oxygen and apart releasing, this is called affinity. And this affinity is not only influenced by the presence of the oxygen, but also influenced by the other factors. One of the important factor is the pH. So whenever there is a decrease in pH, means whenever the acidosis will be there, it loses the affinity for the oxygen, for the hemoglobin. And more oxygen will be released by the hemoglobin into the site where the pH is low. And now कहाँ पे pH low होता है? Lungs, there is a pH is higher because there is oxygen is there, and pH is directly related to the carbon dioxide concentration. CO2, tissue metabolism हो रहा है, tissue का metabolism हो रहा है, CO2 release हो रहा है, that CO2 will combine with the water and it will form H2CO3, and this H2CO3 will again dissociate into H plus ion plus HCO3 minus ion, and this H ion will release into the blood, and that will decrease the pH or increase the acidity of the blood, and that will loses the affinity and more oxygen will be released. So जो टिश्यू ज्यादा मेटाबॉलिज्म कर रहा है, more carbon dioxide will release, it will release more carbon dioxide release हो रहा है, तो उसको ज्यादा ऑक्सीजन की जरूरत है, तो there will more oxygen will be supplied. So it is like a demand and supply. तो ज्यादा कार्बन डाइऑक्साइड रिलीज हो रहा है, तो उसको ज्यादा ऑक्सीजन यूटिलाइजेशन की जरूरत है, and that will release. Similarly, this happens when we are doing exercise. So when you are doing severe exercise, so muscles which are exercising will have more metabolism, more and more carbon dioxide will be released, and that will stimulate more and more release of the oxygen as compared to the muscles which are not exercising. Apart from this, not only carbon dioxide which decreases the pH, but also when there is the oxygen supply is not proper, or whatever oxygen is supplied is not enough, Then the glucose is metabolized with a non-aerobic metabolism, anaerobic metabolism, and that will lead to formation of more pyruvic acid and lactic acid. And these will also start lowering the pH, and that will more and more release of the oxygen will occur. Apart from this, temperature is also very important factor. Okay, this effect of the pH is called Bohr's effect. When we'll discuss respiratory system, that time we'll talk about the Bohr's effect. So this effect is also called as a Bohr's effect. Okay, apart from this, another factor is temperature. So whenever there is increase in temperature, that leads to decrease in affinity for the oxygen. So temperature जब भी increase होगा, affinity will be decreasing. Okay, and it can similarly जहाँ पे metabolism ज़्यादा होगा, वहाँ पे temperature heat production भी ज़्यादा होगा, and that how the more metabolizing tissue will get more oxygen, less metabolizing tissue will get less oxygen. So जहाँ पे demand ज़्यादा है, वहाँ पे oxygen ज़्यादा जा रहा है, जहाँ पे demand कम है, वहाँ पे oxygen कम जा रहा है. Then another is concentration of 2,3-diphosphoglycerate. These are usually older RBCs has a higher concentration of 2,3-diphosphoglycerate, and this older RBC hemoglobin will has a lower affinity for the oxygen as compared to younger RBC. Okay, so these are the factors which affect the hemoglobin affinity for the oxygen. Apart from this oxygen transport, hemoglobin also plays very important role in carbon dioxide transport. Now, oxygen attached to the ferrous atom, but the carbon dioxide attached to the globin part, and will form carbiminohemoglobin. Okay, and in that form, the carbon dioxide carries by the hemoglobin and release it to the lungs. This whenever carbon dioxide attached to the globin, that carbon dioxide directly inhibit the oxygen affinity of the hemoglobin, and that will lead to more release of the oxygen. ज़्यादा carbon dioxide होगा तो hemoglobin को direct touch होगा, and this is how it will release. Apart from the hemoglobin, carbon dioxide also carries by the proteins, that is globin present in the blood, albumin present in the blood, and also in the free form, that is in the form of H2CO3. So these are the three forms in which the carbon dioxide is moves from the tissue to the lungs. Then apart from this, hemoglobin is also forms a very good buffer system into the blood, and it acts as a H ion donor and H ion recipients whenever there is a any disturbance in the acid-base balance. So whenever the H ion is increased, acidosis will be there. Then hemoglobin will release OH ion, or H ion will combine and try to reduce the H ion content in the blood, and opposite effect will be there whenever there is a alkalosis will occur. So it plays very important role as a buffer system. Now come to the varieties of the hemoglobin. As in a previous slide I already told, there are three different types of the hemoglobin normally found. That is physiological varieties. First and common is hemoglobin A, which is usually seen in the adult, and it contains 2 alpha and 2 beta chain. Remember this, alpha and beta chain in the egg hemoglobin. यह भी आपको पैथोलॉजी में आगे काम में आएगा. Then there is a variations of the adult hemoglobin is one is HbA2, that is another variation, and in which alpha and delta, 2 alpha and 2 delta chain will be there. And then another hemoglobin is fetal hemoglobin, which is usually seen in the intrauterine life in the fetal RBC, and it will be remaining to the blood up to the 2 to 3 months of the birth, and this contain 2 alpha, 2 gamma peptide chains. Okay, now HbA and HbA2 functionally almost similar, but HbF has a little bit different because it is specialized for the fetal circulation, and it has a very high affinity for the oxygen as compared to HbA, and because of that they can take the oxygen from the maternal blood into the fetal blood, because of fetal hemoglobin has a higher affinity as compared to maternal hemoglobin. Second thing, the lifespan is very small, and they will destroy within 1 to 2 weeks, while this hemoglobin A will have almost 4 weeks of the lifespan. And then alkalis, it doesn't have any effect of alkalis. Then come to the abnormal hemoglobin pathologically, and that is called hemoglobinopathy. One abnormality can be when there is a defect in uh, synthesis of the chain. So abnormal chain will be formed. So abnormal polypeptide will be formed, and that condition is called that one condition is hemoglobin, sickle cell hemoglobin, also referred as a hemoglobinase. Here the beta chain is affected in the individual. Second condition where one particular chain will not form at all. Normally HbA2 is present in our body. Out of all hemoglobin, 2 to 2.5% of the hemoglobin is HbA2. When the particular chain is synthesized is only completely suppresses, that condition is called thalassemia. So if alpha chain is synthesis suppresses, then we call it of alpha thalassemia. If beta chain is synthesis suppresses, then we call it as a beta thalassemia. Other कोई chain का suppression हो रहा है, then that will not clinically appear because we need alpha and beta chain only. Now come to the sickle cell hemoglobin. These are very common in Africa. Almost 10 to 20% Negroes shows sickle cell hemoglobin. And here defect is the valine is substituted instead of glutamine. So glutamic acid की जगह valine जाता है and sixth position of the beta chain, and that leads to sickle cell hemoglobin. So that will report as a HbS. And this HbS hemoglobin has a typical property that it can easily precipitate. So they are very less soluble as compared to HbA, and that they can easily precipitate. And this precipitation is enhanced by the low oxygen saturation. So whenever there is a little bit hypoxia, it will create the precipitation. Once the precipitation will be there, the hemoglobin will form elongated like shape structure, and the elongated shape will make the biconcave RBC into rigid sickle cell RBC. And this mechanism is called sickling of the RBC. And this RBC will now become very less flexible, and they can trap between the small capillaries and break into, destroy into the causes destruction or hemolysis of the RBC. Apart from this rigid RBC also increases the viscosity of blood vessels and can decrease the blood flow and can cause a multiple infarct. So this is how the sickling occurs. So whenever the oxygen is less, it will become most precipitate rods will be there, and these will combine each other and form the sickle cell, like this shape. Then come to the Now the sickle cell are two types. Fragile means easily broken. It can break easily, like glass. If you see wood and glass is much easily fragile as compared to wood. So जो easily broke हो जाता है. Okay, जैसे तुम्हारी गर्लफ्रेंड का दिल बात पे टूट जाता है. That is fragile. Okay, now you'll remember. Then sickle cell are two types. If the both genes genes are defected, then there is no normal hemoglobin will form. So all hemoglobin will be sickle cell hemoglobin, and that is called major type of the sickle cell, and that clinically very severe sickle cell, and it need very aggressive treatment, and treatment of sickle cell anemia is blood transfusion. Minor type of the sickle cell where the one gene is only 50% normal hemoglobin form, 50% sickle cell hemoglobin form, and person can survive. There will be the anemia, but person can live normal life without much treatment. But you need to only prevent from the severe hypoxia. Like cold में चले जाओगे तो hypoxia हो जाएगा, and that can lead to sickle cell crisis. Then come to the thalassemia. Whenever there is a defect in alpha chain synthesis, we call it alpha thalassemia. When defect in beta chain synthesis, we call it beta thalassemia. Alpha thalassemia, major condition, when both gene is affected, then we call it as a alpha thalassemia major. When only one gene is affected, we call it as a minor. Now in alpha thalassemia, as you know, all three normal hemoglobin contain alpha chain common. So in alpha thalassemia major, if alpha gene is absent, then there is no normal hemoglobin will synthesize even in intrauterine life, because hemoglobin F is also need alpha polypeptide chain. The alpha polypeptide chain is not synthesized, and that person will have very difficult to survive. And there is a clinical case we will not able to see, because patient will not born. Before birth only patient will die. But alpha thalassemia minor you can see normally, and that person will live normal life with a mild type of the anemia. And in this case, you will see chain which contain hemoglobin, which contain 4 gamma chain. Instead of 2 alpha 2 beta, it contain 4 gamma chain also, and that is called bar hemoglobin or hemoglobin bar. Then come to the beta thalassemia. Beta thalassemia is more common because a person survives longer. So if there is homozygous transmission, we call it as major, or both gene is affected, then beta chain is not synthesized at all. In these conditions, adult hemoglobin in fetal life is normal because it contains alpha and gamma chain. There is no role of the beta. But as we progress to normal life, now here HbA2 synthesis will be higher. So almost 90 to 80% will be HbA2, and remaining part will be HbF. Okay, that will be there in a homozygous, but HbF has a low lifespan, so it will create a severe anemia and need to regular treatment, and treatment here is also blood transfusion. If you come to alpha thalassemia minor, here HbA is also synthesized, HbA2 is also synthesized, and HbF is also synthesized. But beta chain is a low, less number of the beta chain has been synthesized because of only one gene available. So all type of the hemoglobin will be synthesized, and this person is lead nearly normal life with a mild anemia and no need to any special treatment. Now, this is a part of the biochemistry. We will not go in detail about all those things. I will share this slide. You can go and read this. Then factors which control the hemoglobin formation. जब तक मम्मी के womb में, till the delivery we call it as a fetus. Just after delivery we call it as a newborn, and then after 1 day we call it as an infant. Okay, so I think we should take a 5 minutes break, then we'll continue. Okay, now we'll start factors controlling hemoglobin formation. So as I said कि कोई भी चीज बनानी हो तो उसके लिए raw material लगता है. So first important is requirement of raw material. So first we'll need protein for synthesis of globulin, then iron for synthesis of the heme, and these other metals like copper, cobalt, and calcium is required for the synthesis of the heme. Then apart from the machineries, for oiling of the machineries, vitamin B12 and vitamin folic acid are required for the DNA synthesis. That is for the maturation of the hemoglobin. DNA is important for the synthesis of other things. Then vitamin C is important for the absorption of the iron and transport of the iron from the site, and also bile salt, which is also important for the absorption of iron and other vitamins. So all these factors are required for the hemoglobin synthesis. Then come to the lifespan and fate of the RBC. So RBC's lifespan is somewhere around 120 days, and Once it become older, it goes to the spleen, and where it's sequestrated and it destroyed. And that is how it will recycle. RBC is recycled in our body. Now, sometimes the lifespan is decreases, and the decrease is with various reasons. First is intracorpuscular, that is defect inside the RBCs. So, like a abnormal shape of the RBC, like spherocytosis or erythrocytosis, that can damage the RBC and increase destruction. Then abnormal hemoglobin, like sickle cell anemia or thalassemia, that increase destruction of the RBC. Then enzyme deficiency, like deficiency of glucose 6-phosphate dehydrogenase deficiency or pyruvate kinase deficiency, that can increase destruction of the RBC and can lead to low lifespan of the RBC. Then come to extracorpuscular, the factor which is outside the RBCs. So mismatched blood transfusion. So that is antigen antibody complex will be there, and that will cause a clumping and increased destruction of the RBC. Then autoimmune RBCs, where antibodies are formed and attach on the antigens present on the RBC cell membrane and increase destruction of the RBC. And then splenomegaly are also called as a hypersplenism, where the spleen size increase, more and more blood goes to the spleen because of increased spleen size, and more and more RBC will be destroyed because site of destruction has been increased. So rate of destruction will be increasing, that leads to decrease lifespan of the RBC. Now what happened once the RBC? So as the RBC become old, that red cell membrane will become more and more fragile because of decreased NADPH activity. That is, NADPH is required for the repair and healing of the red cell membrane. The decreased activity will causes decreased repair and healing, and that leads to red cell membrane become more fragile. And now because of that increased fragility of the red cell membrane, these RBCs goes into the capillaries of the spleen, and where the spleen lumen of this capillary is very small, and they're stuck to those capillaries and to try to squeeze through that capillaries, and because of fragile cell membrane, the cell membrane will be teared and it causes destruction of the RBC. Once the RBC is destroyed, that is called hemolysis, the hemoglobin will release from the cells, and that hemoglobin will be taken up by the tissue macrophages which are present into the spleen. This tissue macrophage which present into the spleen, not only the spleen, other part of the spleen also, and also in the liver, with this tissue macrophage will taken up, and then they will separate the globin and heme part separately. Globin will be recycled as a protein, separated into two amino acids, and that amino acid will utilizes for the synthesis of the new protein, while the heme part will be released, oxidized into methane form, and type R link structure will be broken, and then it will convert it into choleglobulin form, and then this converted into the ion will be removed, and it will convert it into tetrapyrrole ring, that is called biliverdin. This biliverdin will reduced by the reductase and converted into bilirubin. That is, this occur bilirubin goes into the liver, and in the liver it get conjugated. This bilirubin is not soluble, that it get conjugated, and then it released into the bile and excreted from the body. Okay, detail of this chemical reaction, all those things you will learn in biochemistry, so we'll not talk much detail about all those things. Then come to the how the bilirubin, once that bilirubin macrophage release this bilirubin into circulation back, and then it unconjugated bilirubin combine themselves with the albumin, and then it goes to the liver or kidney, and in kidney they try to release in the form of urobilinogen. In the liver, this unconjugated bilirubin is bound to the albumin, will convert it into conjugated form by enzyme called glucuronate combined with the urine diphosphate glucuronic acid and make it into water soluble, that is called conjugated bilirubin, and this reaction is catalyzed by the glucuronyl transferase. This conjugated bilirubin goes into the enterohepatic circulation, that is excreted in the bile and enters into the intestine. Some of this will be goes directly to the kidney, not into the bile. Will go directly into the kidney and release as a urine bilirubin. Now, once the conjugated bilirubin enters into intestine, it is degraded by the intestinal bacteria and terminal ileum, and they release into the feces, and that gives that golden color to the golden yellow color to the fetus feces. This is called streptobilirubin. Some of this reabsorb, and then it's secreted into urine as a urobilinogen. Okay, so this is how the bilirubin and all those things cycle will be occur. Now, if you see this bilirubin continuously keep on forming and release into the liver, then into stool, and also into the urine, it will maintain some concentration into the blood, and that concentration normal individual will be around 0.3 to 1 milligram per 100 ml of the blood. Okay, this concentration can measure in lab by one Denver test, and now we had a cell analyzers and auto analyzer. There also we can directly measure. And when this concentration increases, and if it goes more than 2 to 3 gram percent, then it can be easily visible, because this bilirubin has a high affinity for the fibrous tissue, and fibrous tissue is present on the skin, sclera, nails. It start depositing in those fibrous tissue and make those tissues appear yellowish color. So जब भी वो skin और इसमें yellow color appearance होने चालू होगा, that condition we call it as a icterus, or also called as a jaundice. Now, jaundice is not a disease. Being a doctor, you will never diagnose any condition as a jaundice. Jaundice is just a sign. तो आप बोलते हैं ना sign and symptom of the diseases. So sign is what doctor observe on the patient. Symptoms what patient told. तो पेशेंट आके तुमको बोलता है कि डॉक्टर साहब मुझे मेरा चेहरा पूरा पीला पीला लग रहा है, मेरी यूरिन येलो कलर की आ रही है, then it is a symptom. But when you observe sclera, yellowish discoloration of the sclera or yellowish discoloration of the nail, then we call it as a sign. So jaundice is actually a sign, and it is how we can define the jaundice. Jaundice can be defined as a yellowish appearance of the skin, sclera, or the mucous membrane because of increased bilirubin concentration into the body, or also called as a hyperbilirubinemia. That condition is called as a jaundice. Yellow colored teeth is a bad oral hygiene. Okay, reason has to be deposition of the bilirubin, then only we call it as a jaundice. Any other there are another condition which is similar to the jaundice is hyperkeratinemia. जैसे कभी कोई आपके घर पे कोई दीदी होगी जो थोड़ी सी सावली होगी, तो दादी उनको गाजर का जूस बना बना के पिलाती कि आप गोरा हो जाओगे. So that carrots contain keratin, that more accumulation of the keratin gives yellowish color to your skin. So that condition we doesn't call it as a jaundice. How we can differentiate between the hyperkeratinemia and jaundice? Sclera will not get a yellowish color in hyperkeratinemia. It is only skin which get yellowish coloration. Okay, and this clinical observable jaundice will be only when the bilirubin concentration goes above 2 to 3 gram percent. क्या देखना है अजीत previous slide में? क्या देखना है? उस पे आएंगे बेटा. कौन अफेक्टेड होता है जॉन्डिस में, लीवर होता है कि स्प्लीन होता है, उस पे आएंगे अभी नेक्स्ट स्लाइड में. कुछ दिखाना चाहता हूँ तुम लोगों को. Poonam, I will repeat hyperkeratinemia, but don't try this to be a fair. Okay? If you had a okay, sorry. if you had a too high consumption of the keratin carotene will be started depositing in our body, and that will create hyperkeratinemia, and that will give yellowish coloration of our body. Okay. Now, how the jaundice appears? As I said, jaundice is not a disease. So there are conditions. Jaundice is increasing bilirubin concentration in the blood. So कोई भी कंटेंट बॉडी में बढ़ना है तो देर आर टू रीजंस, आइदर उसका प्रोडक्शन बढ़े या उसका डिस्ट्रक्शन कम हो जाए. कोई भी चीज़ अगर बॉडी में बढ़ेगी तो एक तो उसका प्रोडक्शन बढ़ेगा या उसका डिस्ट्रक्शन कम होगा. सो प्रोडक्शन कब बढ़ेगा? बिलिरुबिन का प्रोडक्शन कब बढ़ेगा? अगर हीमोग्लोबिन का डिस्ट्रक्शन ज़्यादा होगा तब बिलिरुबिन का बढ़ेगा. सो फर्स्ट कंडीशन hemolytic jaundice. So whenever there is increased hemolysis and that create jaundice, that is called hemolytic jaundice. And as this condition occur before liver is affecting, तो लिवर के अफेक्ट होने से पहले ही bilirubin concentration बढ़ रहा है. And that's why it is also called as a pre-hepatic jaundice. Second condition, production तो normal ही है, it is not affected, but उसका excretion नहीं हो रहा. Excretion कब नहीं होगा? अगर उसका conjugation proper से नहीं होगा, liver में से वो बाहर नहीं जा रहा, liver उसको conjugate नहीं कर पा रहा, so it will not able to excrete it properly, so it will start accumulating in the body, and that condition is called hepatocellular jaundice or hepatic jaundice. It can be occur because of damage to the liver cells, like alcoholism, बहुत ज़्यादा अल्कोहल पीते हो, this is toxic hepatitis, or in viral infection, okay, that damages liver cells. Viral hepatitis, type A hepatitis, type B hepatitis, type C hepatitis, all type of infective hepatitis, that can also causes liver cell damage, and that can lead to jaundice. So that is hepatocellular jaundice or hepatic jaundice. Third thing, liver is also normal. It is conjugating the bilirubin and it releasing into the bile, but from the bile it is not moving outside the body. So there is obstruction in the bile duct system. So as it causes obstruction, it can also cause obstructive jaundice or post-hepatic jaundice, or because of stoppage of the bile also called a chole. So stoppage of the bile, that's why it is also called as cholestatic jaundice. Okay, so these are the three mechanisms which can increase the bilirubin condition. So अगर pre-hepatic jaundice है तो क्या होगा? अब जैसे हमने okay, pre-hepatic jaundice. प्री-हेपेटिक जॉन्डिस. प्री-हेपेटिक जॉन्डिस में क्या हो रहा है? ए सिस्टम आपका अफेक्ट हो रहा है. So there is increased destruction of the RBC, and it will create unconjugated bilirubin. That will be more and more. Whatever bilirubin is conjugated here, it will goes into bile. Bile से जा रहा है, and it goes into the intestine और recircle हो रहा है. 20% back जा रहा है, 80% excreted हो रहा है, ये normal हो रहा है. But it concentration keep on increasing so and so. Now it goes beyond the capacity of liver to conjugate those bilirubin, and now it will increasing the unconjugated bilirubin concentration into the blood. So whenever you will see there is a more increasing unconjugated bilirubin into the blood. Apart from this, it shows free hemoglobin inside the blood. क्योंकि RBC का destruction हो रहा, तो hemoglobin will release into the blood. So there will be the hemoglobinemia. Increase unconjugated bilirubin, and since hemoglobin अगर free form में होगा तो urine में भी आएगा, तो it will also leads to hemoglobin urea, HBurea, hemoglobin. So urine में hemoglobin भी दिखेगा, unconjugated bilirubin भी दिखेगा, and that leads to and there is no bilirubin, urobilinogen will not be in the urine, होगा, urine bilirubin भी बढ़ जाएगा. Unconjugated bilirubin in the urine also, that will also increase. So, but a conjugate bilirubin will be normal or little higher because conjugations तो हो रहा है. So this condition will give you idea about a hemolytic anemia. So more important is hemoglobinuria, hemoglobinemia, and high concentration of unconjugated bilirubin. The next condition in hepatic jaundice. Now here RBC destruction and all those things are normal, but conjugation is not happening because of damage to the liver. Now what will happen? As the conjugation is not happening, the conjugated hemoglobin will be very low. Conjugation unconjugated will be very high. But there will be no hemoglobinuria, there will be no hemoglobinemia, वो सब नहीं होगा. Okay? And also the stool color will also yellow because it is releasing conjugated bilirubin, and urine bilirubin will also be normal. Okay, so hemoglobinemia, hemoglobinuria नहीं होगा, but conjugated hemoglobin concentration बहुत लो होगा. जो hemolytic anemia में high था, इसमें low होगा, but unconjugated बहुत ज़्यादा दोनों high में होगा. That will give you idea about a hemolytic hepatic jaundice. Now third condition, where obstructive jaundice, where this path is obstructed. RBC production destruction normal है, normal bilirubin form हो रहा है, but conjugation भी हो रहा है, but now it is not going at. So once it is not going outside the body, it goes back. It bounces back, and it from the liver, it start accumulating in the liver. From liver, it goes to the blood. Okay. Now there is increased concentration of urobilinogen, because more and more bilirubin goes into the blood and it will release into the urine. Second thing, stool color will be completely clay color. There is no bilirubin into the stool, so yellowish color nahi rahega. So it will be clay color stool. Second thing here, unconjugated bilirubin normal hoga, while conjugated bilirubin will be much higher concentration. Okay. So these are the signs where you can find it is post-hepatic or obstructive type of the jaundice. Okay, समझ में आया jaundice? Then there is one special condition called physiological jaundice of the newborn. As I already discussed, the hemoglobin concentration is much higher in the newborn, and it immediately start increased destruction of the RBC in the immediately after the birth, and because of that, there is more production of the bilirubin into the newborn. But at the same time, newborn liver is very immature, so it is not enough to process that higher dose of the bilirubin, and so bilirubin will be start accumulating in initial first week of the birth, and that is called jaundice of newborn or physiological jaundice of normal. There is no additional care is needed, and by the second week it will start disappearing and it will remove from the body. Okay, because of this it increases. If you think the concentration is very high and it can damage, because blood-brain barrier of the newborn is also not very much developed, so it can bilirubin can deposit into the brain and can damage the brain tissue. If you think all those things, then there is simple treatment will be there, phototherapy. You will expose that individual to the ultraviolet lights, and that will increase the conjugation of the more effective or more dangerous. Jaundice treatment to नहीं दे रहे हम. All three jaundice are dangerous to our life. हाँ सुशांत, मैं क्लास में हूँ. मैं 10-15 मिनट में कॉल करता हूँ. एक मिनट मैडम से बात कर लो. कॉल बैक कर लो. सुशांत. Okay, one which is more dangerous. All three jaundice are very much dangerous. Hemolytic anemia होगा तो it's a patient is already suffering from the anemia. Bilirubin concentration body के अंदर बढ़ते जा रहा है. That can deposit in different part of the tissue that can damage our body, even kidney also. So it need to treat aggressively. Hepatic jaundice, if liver cells damage permanently, then it will become jaundice. It will be very difficult to treat. So prognosis is very poor for the hepatic jaundice, specifically if it is because of either alcoholic liver disease or type B or type C type of the hepatitis. In this condition, person can land it into cirrhosis. Okay. प्रीवियस पॉइंट बेटा क्या प्रिवेंशन पॉइंट ओके उस पे आ रहा हूँ पहले कुछ और क्वेश्चन है तो hepatocellular jaundice is very difficult to treat because liver cell has been already damaged, and if it already developed cirrhosis, then it will be irreversible damage to the liver, and then it will be very difficult to treat. Easiest way to jaundice which can be treated is obstructive jaundice if it is not malignant obstruction. Gallbladder stone है, gallbladder निकाल दो. Any obstruction है, that surgically you remove that obstruction and the patient will be recovered completely. Okay. Now someone is asking me about the prevention. This is not prevention or treatment. Prevention आप पहले ही उसको enzymes दे दो or any agent which can increase the enzymes into the hepatic cells, that inducers you can inject it, and that can metabolize the bilirubin and prevent the physiological jaundice. Treatment phototherapy will expose that newborn to the light, and light will increase the conjugation of the bilirubin, and that can easily removed from our body under the influence of the light at the skin. Okay, so that's all about the jaundice. Now I will take a shortly about the anemias. Anemias, we can define anemia as a decreased oxygen carrying capacity of the individual or blood, decreased oxygen carrying capacity of the blood, either because of decreased RBC count or because of decreased hemoglobin content. Okay, this is how we can define anemia. According to WHO criteria, if hemoglobin in the male it is below 13 gram percent, then we consider it as anemia. In female, it is when it goes below 11.5%, then we consider it as anemia. In newborn, if it goes below 15 gram percent, then we consider it as a anemia. And in the infants, if it is come below 10 gram percent, then we consider it as a anemia. RBC count less than 4 million, we will consider as a anemia. Then we had a grading, also grading of the anemia. Mild anemia 8 to 10, moderate 6 to 8, and severe is below 6 gram percent. Okay, so these are the grading, and grading is important. Mild anemia you can treat on dietary basis, diet से हो जाएगा, hematinics भी हो जाएगा. Moderate we need a proper medication treatment along with the diet, and severe anemia oral medication may not be effective in anemia, so either we have to give IV or intramuscular medications, and if a person has some emergencies, then we can also go for the blood transfusion. Now, what are the causes? Depend upon the cause, we can classify anemia like a deficiency anemia, blood loss anemia, hemolytic anemia, aplastic anemia, or anemia due to chronic diseases. Okay, so deficiency anemia, whenever there's any nutritional deficiencies are there, like iron deficiency anemia, vitamin B12 or folic acid deficiency anemia, or protein or vitamin C deficiency can also cause anemia. So in these conditions, if you replace those particular elements, then anemia will be recorded. Out of this, iron deficiency anemia is one of the commonest type of the anemia in India. Then anemia because of blood loss. So it can be like a chronic hemorrhage. So throughout body में से blood loss जा रहा है. Example, peptic ulceration, hemorrhoids, hematuria. All these conditions, the blood will keep on losing from the body, and that can lead to anemia. Sometimes acute anemia, suddenly any accidents, any surgery, in this condition blood will be lost. That time also leads to anemia. One condition which regularly occur, it is related to female, whenever there is a related to menstruation. When there is increased blood loss in the menstruation, that is called polymenorrhea. sorry, menorrhagia, or increased duration of the blood loss. So normally periods 3 दिन के होते हैं, किसी किसी में it can go up to 7 days or 10 days. Then we call it the polymenorrhea. In this, blood regularly losing from the body at the high amount, and that can also lead to anemia. Here the treatment is prevention of the blood loss. What are cause? If you know, you prevent that blood loss. And if in usually acute hemorrhagic anemia, acute blood loss, we usually replace it with the blood, and we can prevent the anemia. Then come to the hemolytic anemias, where destruction of the RBC is increased either because of intensive factors like thalassemia, hereditary spherocytosis, sickle cell anemia, or enzyme deficiency anemia, or because of acquired factors like uh, uh, hemolysis because of any toxins like a lead or cadmium toxin, hemolytic anemia because of splenomegaly, or hemolytic anemia because of antibodies like paroxysmal nocturnal hemoglobinuria. In those conditions, it will increase destruction of the RBC, and that leads to anemia. Now, treatment: thalassemia, sickle cell anemia, spherocytosis, and all these will require regular blood transfusion. So हर 3 महीने में, 4 महीने में, या 2 महीने में, depend upon the severity of disease, they need a regular blood transfusion. Then is the acquired deficiency. These are usually mild type of the anemia and doesn't require any treatment. Like there is a paroxysmal nocturnal hemoglobin. It is usually decreased body temperature, which causes antibodies to be active and leads to hemolysis, and that leads to morning you will see the coffee color urine because of these antibodies. Splenomegaly, you can remove the spleen if anemia is severe, because if the anemia occurs because of splenomegaly, it will not cause only anemia, but it will also called as a thrombocytopenic purpura. So these both conditions can be cured by just removing the spleen. Then come to the aplastic anemia, where the bone marrow is failed either because of irradiation, or because of cytotoxic drugs, or because of metastatic deposits of the malignant tissue and replace the complete bone marrow, and that leads to decrease in RBC production. So here, if you know cause like a cytotoxic drugs, so take a proper cycle of the cytotoxic drugs so that it will gives enough time for bone marrow to recover from that. If it is irradiation, then prevent the irradiation, and final treatment can be bone marrow transplantation. Okay, then anemia due to chronic diseases, it usually affect the kidney and reduce the erythropoietin production, like in tuberculosis or chronic infection of the renal diseases, malignancy, all those things. Even these also associated with the nutritional deficiencies, or body is not responding. Even if you are giving oral medications, they will not get absorbed properly, and that's how it produces anemia. And treatment is treat the cause, disease, anemia will be recovered. Then morphological classification depend upon the size and shape of the cells. It can be classified like a normocytic normochromic anemia when the cell size is normal and color of the cell is also normal. That is called normocytic normochromic anemia. It can see in acute hemorrhagic anemia, hemolytic anemias, and aplastic anemias. The microcytic hypochromic, here the size of the cell is little bit lower, and hemoglobin content of the cell is also very less, and that causes microcytic hypochromic anemia, that you can see in iron deficiency anemia, thalassemia, and chronic anemia because of chronic hemorrhages. Then microcytic normochromic anemia, that you can see in two conditions: vitamin B12 and folic acid deficiency. And these general clinical features, anemia is a very common disease, and patient usually don't come to you for a treatment of the anemia. So when your patient comes to you for any other condition, you always look for the anemia. Anemia आप कहाँ check करोगे? You will check it on a palpable eyebrow. Normal reddish color होता है. In anemic patient, it is very pale color. Tip of the tongue. Then you can see the palm. Palm पे आप elevations पे देखोगे यहाँ पे. It is pinkish and reddish in color. In anemic patient, it is very pale in nature. So all those sides you can look for the anemia. Apart from this, many times patient complains. Very vague complaint will be there, like a generalized weakness, tiredness, कहीं मन नहीं लगता, कुछ करने का मन नहीं करता, Then sometimes also lack of appetite, anorexia will be there. All those things you can easy fatigability. So पहले तो मैं 2 किलोमीटर चल लेता था, अभी आधा किलोमीटर चल के भी थकान से लग जाती है. All those things with dryness of the skin. Then if iron deficiency anemia, the nails will become very thin and brittle. So all these features will be there. Increased heart rate, tachycardia, palpitation will be there. Increased respiratory rate, breathlessness will be there. Uh, Sadness, it is irritability, fatigueness, very restlessness, tiredness, drowsy. All those things will be will appear on the condition, and this how you will able to diagnose the anemia. And how you can diagnose anemia? By simply hemoglobin content, RBC count, and peripheral smear में to see the RBC morphology. That will be enough to diagnose the anemia. No need to do serum iron level, transferrin level, or folic acid level, vitamin B12 level, and all those things. And how you can treat any anemias? There are 3 ways to treat anemia. First, dietary basis. If cause knows, then remove the cause. If cause is not known, then a dietary basis. Improve the diet. Ask the patient to have a high protein diet with green leafy vegetables. If he's non-vegetarian, to have the non-vegetarian foods on regular basis. Then next is the medications. Usually we prefer oral medications. And nowadays hematinics, the medications which increase the hemoglobin count are called hematinics. So the hematinics contain iron, vitamin B12, folic acid. All these 3 content will be there. So and other like zinc, calcium, and copper also there, and that will increase the hemoglobin concentration. So once you start treating, by the end of the 1 month, each month 1 gram of the hemoglobin concentration will be keep on increasing. If a patient is responding like that, that is a proper treatment and will respond. If patient is not responding to oral treatment, then last option will be injectables. So injectable can be given by intramuscular or IV, depend upon the patient diagnosis. If iron deficiency anemia, we can give. If vitamin B12 deficiency, vitamin B12. And if in severe condition, if there's a severe type of the anemia and patient is have some emergency like a pregnancy, or a patient has to operate for something, then we can treat them with a blood transfusion. But blood transfusion should be last option because it has one side effect, and we need to look for all those things also. So there are always pros and cons for the blood transfusion, and we should also see for the pros and cons, and then only we should decide for the blood transfusion. Okay, that's all for today. Any question, any doubt? Any questions, any doubt? Okay, then. Thank you. Next class we'll talk about plasma proteins. 1 minute. Okay, bye.